Good evening, everyone, and welcome to the National Pancreas Foundation's virtual education webinar. I'm Trish O'Neill, the National Director of Chapter Development. The mission of NPF is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Partnering with over 160 centers of excellence throughout the U.S., some of our featured programs include the Animated Pancreas Patient, the NPF Cookbook and Pocket Guide, offered in hard copy, as well as a free download, the African American Initiative, our patient registry, state chapters that support education, fundraising, and patient support, and our physician programs that include research grants, medical education, and our annual fellow symposium. Our success depends on support of many individuals and organizations. Please consider taking an active role in furthering the mission of NPF by sharing your personal story, making a donation, or joining a chapter in your local community. For more information, please visit us at pancreasfoundation.org. Our topic this evening is how to improve communication with healthcare providers. Tonight's session is presented in partnership with NPF Center of Excellence, Cedars-Sinai Medical Center, with Dr. Stephen Pandal and Dr. Sri Gadam, and special presentation from NPF's co-founder, Jane Holt, on our patient registry program. Please use the Q&A section of the portal to submit your questions, and they will be answered at the end of tonight's presentation. Dr. Pandal is currently Director of Basic Translational Pancreas Research at Cedars-Sinai Medical Center and Professor of Medicine at Cedars-Sinai Medical Center and the David Geffen School of Medicine at UCLA. Dr. Pandal is co-leader of the United States Consortium on Chronic Pancreatitis, Diabetes, and Pancreatic Cancer, which is developing methods for early identification and treatment of pancreatic cancer. He is a past president of the American Pancreatic Association and currently the editor for Frontiers in Gastrointestinal Sciences and a past associate editor for the American Journal of Physiology, Gastroenterology, and Hepatology. He is a leading international authority in gastroenterology and pancreatology. Dr. Pandal heads a large research group devoted to understanding the mechanisms underlying several medical disorders, including inflammatory diseases and cancer of the pancreas. The research is designed to provide information needed for treatment and prevention of these disorders. He has published over 300 scientific articles, book chapters, and topic reviews, and he lectures and leads symposia frequently and internationally about his research results and outlining mechanism-based strategies for treatment of medical disorders. Thank you, Dr. Pandal, and for all the presenters for being with us this evening and providing expert information on this important topic.
Thank you so much, Trish. It's wonderful to be with everybody tonight. My role is to give a little bit of a primer about some of the basic underlying problems with pancreatitis and how to talk to your doctor about those underlying problems. Because I would say that you might be the best source of information often when you go to an emergency room or a doctor who may not know your case or who is unfamiliar with pancreatitis, because not all doctors are. And so the seminar tonight is to give you information to communicate better with your healthcare providers. So the title of what I'm going to talk about is what causes pancreatitis and why. Dr. Gavin will follow with strategies for therapy. So we'll start with just what causes pancreatitis and why does that happen. So I thought it would be a good idea just to give you an idea of the machinery of the pancreas. The pancreas is actually a little more complex than sometimes we think about. It has both these on the, I hope you see my arrow, has these spheres that are called islets of Langerhans, and they contain the metabolic hormones like insulin that regulate your blood sugar. And those are embedded in the larger organ that is this more brown, yellow colored animation that I have that has these like little machines that have cells. A cell has these nuclei that are purple, and then the cells are purple, surrounding a canal system. And that canal system carries digestive enzymes that digest your food through these smaller canals to start with, and then to larger ones that put those digestive enzymes into your intestine to digest your food. And so what you can see is there are these we call them acini, but they're spheroid kinds of structures that make your digestive enzymes, then put them in this canal structure, and then the canal structure carries those digestive enzymes into your duodenum. So you can imagine if you have something that blocks up the canals, or if there's some machinery problem, a different kind of machinery problem within the cells, whether they be in the cells that make the digestive enzymes or the canals, you would expect there could be some disorder. And that's actually what happens in pancreatitis. There are disorders in these different structures. And I'll try to explain those a little bit more as we go along. The important point, though, is that these exocrine, we call them exocrine because they put those digestive enzymes towards the outside of your body. Outside is your digestive tract going to the outside world. And connected to the endocrine pancreas, which keeps all of the secretions like insulin inside your body. So that's actually what I teach to first-year medical students. So this is a little more detail, and I call it the pancreas team. So instead of more of a cartoony picture, this actually, the picture with the red, purple structures is actually a histological examination of a normal pancreas, what we would see under the microscope of a human pancreas. And the round ball in the center are those endocrine cells, and it's called an islet of Langerhans. And some of these cells, more towards the middle, contain insulin. And the outside are the digestive enzyme cells, and the digestive enzymes are actually purple. There are little granules that stain red when the cell is alive. And it actually stains red because it's more acidic inside those granules. And those are digestive enzyme stores that in a cartoon on the right, I have as little brown vesicles. And those are what stains red on the left. And so again, we see those cells that make the digestive enzymes. They're stored in these brown, this cartoon shows them as brown vesicles that contain the digestive enzymes. When you eat a meal, these cells are stimulated by neural stimuli. In other words, they start secreting as soon as you start thinking about eating, actually. That's called the cephalic phase of the meal. And they secrete those digestive enzymes into the lumen, and that's where my arrow is. And that luminal space, lumen just means like a space in a canal, for example, into these ducts that carry out the digestive enzymes into the intestine again. I want to point out more here where the ductal cells are really important because they secrete water that actually acts like a river to take those digestive enzymes into the duodenum. And actually, if we look at the opening in the intestinal tract where this canal comes out, if you're stimulating the pancreas, you actually see a squirting of water come out. And that water is carrying the digestive enzymes coming from the digestive enzyme factories through the canal structure. So again, you can imagine if the water system, for example, coming from the duct doesn't work, you can't carry those out, and that can cause backwards injury, pressure and injury into the pancreatic structure. And also you can imagine if these digestive enzymes, which digest your meal, if they get caught up and can't get secreted here into the lumen, you also could have a problem because they can actually cause damage by eating your pancreas, just like they would eat your meal. The only other structure that I'll point out here is these octopus-looking cells. They're called stellate, which stands for more star-like cells that surround these structures. And they actually act like as a glove around, with their fingers around these structures. Normally, they actually help form the structures, but when you get an inflammatory disease of the pancreas, like pancreatitis, they actually change. They change into like devils almost. They start making inflammatory molecules and scarring molecules that are the fundamental problem that happens with persistent forms of pancreatitis. But this is the basic team that I'm going to talk about. This team, though, I will say, can recruit inflammatory cells from your blood, from the circulation, when you get the inflammatory process going on. So this team has the ability of bringing in from the outside, from your bone marrow and from your blood, inflammatory cells that help them cause disease when they get out of control, when they're not working as good, let's say, players should. And so that's the nature of the disease. So this is a slide I've used over and over to kind of show the relationship between having an acute episode of pancreatitis to recurrence, chronic, and in rare cases, pancreas cancer. And on the outside, I have things that could be promoting these, like smoking and alcohol, diabetes and obesity, and also multiple mutations in the systems I've just been talked about, mutations here in digestive enzymes, but also mutations in making the water flow in the ductal cells. So these are, all, we'll call it causative factors that then activate pathways, inflammatory pathways that start with acute pancreatitis, but can go on to return attacks to go to chronic pancreatitis. And sometimes, in rare circumstance, that sets up the stage for pancreatic adenocarcinoma or pancreatic cancer, and sometimes diabetes, which we often call now type 3C diabetes. So these are the names of the disorders. And Dr. Yadav, who's very active and a collaborator of ours in the field from Pittsburgh, and Dr. Lowenfels, who was from New York, published in 2013 a really nice Venn diagram to explain this in a kind of a proportional way. And it points out that pancreatitis can occur with gallstones or without gallstones, so-called non-gallstone pancreatitis. And this sphere circle gives the rough proportions. It's about 50-50 or maybe a little bit more of non-gallstone. Now, you can see that the gallstone pancreatitis doesn't go down by this pathway of recurrent attacks and chronic pancreatitis that I've just been talking about. That is because when we find somebody has a pancreatitis from gallstones, we tend to fix the problem and there's no more recurrence. However, in other cases, like the genetic disorders, like smoking and alcohol, maybe diabetes, and some of the mutations that can be underlying the causative factors in pancreatitis. And by the way, we're finding more and more the more we look for them. Those patients can go into recurrent cases. So you can see the circle of recurrent cases is like 20% of this group of non-gallstone acute pancreatitis. So it's about 20%. And then you can see a fraction of those, maybe 30, 40% go into chronic pancreatitis. Now, you can see that some of the circle is outside the recurrent, and that's because some chronic pancreatitis shows up without having recurrent attacks. And it's probably by a different pathway, but we don't understand it as well. And then finally, a very small portion, you can see this little sliver of overlap with pancreatic cancer can go into pancreatic cancer. But for the most part, pancreatic cancer comes from outside this group of itis diseases, pancreatitis diseases. Okay. So another key concept is that chronic pancreatitis doesn't happen over, like one episode. It's usually like this. It's usually like you have these acute episodes represented by these blue arrows, and each time you get an acute pancreatitis attack, it's called recurrent. So this would be recurrent acute pancreatitis attacks with each of the blue ones. And then it shows that you can get some scarring, or it's called here fibrosis, with each of those attacks. But you see, if you have the attacks frequently enough, you start to accumulate more and more of that fibrosis. And that fibrosis then is scarring. And the nature of chronic pancreatitis is there's this fibrosis and there's inflammation from these episodes of pancreatitis. So we call it often fibroinflammatory. That is fibrosing and inflammatory disease. And a little bit later, I'll show you that those two are connected. Very rarely, and this is a case that we use that was published in 2004, very rarely we have a disease like hereditary pancreatitis where there's a mutation in an enzyme that makes trypsinogen, a key enzyme in your pancreas, so that you get spontaneous activation of trypsin, which causes pancreatitis. And it does so by messing up the cellular machinery, basically. And you can see the first episodes can occur in before 10 and in the teenage years. And those are recurrent episodes, just like I've been talking about. But over time, you lose the pancreas is replaced. The normal pancreas that I've described as the pancreas gets replaced by this fibrous and inflammatory tissue. So you don't have much of the normal tissue left. So we get what's called malabsorption. That means you're not making enough digestive enzymes to digest your food. So over time, and you can see it takes several years, you start maldigesting your food. And some of those patients also get diabetes. And lastly, at later ages, in a small proportion of patients, pancreatic cancer can develop. So this shows the sequence I've been describing kind of in multiple different ways. This is by far the most aggressive of the pancreatitis phenotypes. And most of them all the rest of them aren't this severe, but this is the most aggressive of them. So the other thing that I always have to help my patients talk to their doctors about is alcohol. So if you go to an emergency room and you have an attack of pancreatitis and you don't have a gallstone, the doctor will say, it's because you're drinking too much, you're an alcoholic, and that's frankly insulting. And so I use this piece of data to kind of show something. So first of all, I know a lot of people who drink a lot. I go to conferences where they drink a lot, and not many people get pancreatitis. So it's pancreatitis as a result of alcohol is a very, let's say, small percentage of people. But furthermore, how much drinking really do you have to do to get pancreatitis? So this is a study by our colleague, Wendy Setiawan from USC, University of Southern California, who has a fabulous research group on the epidemiology of pancreas diseases. And they follow 250,000 patients since 1996 in something called a multi-ethnic cohort, meaning they have matching ethnic groups like African Americans, Hispanics, Asians, Caucasians, and even Hawaiians. They do it between California and Hawaii. And what they did is they took those patients who have the non-gallstone pancreatitis. So I have gallstone pancreatitis on the left and non-gallstone pancreatitis, which includes recurrent acute pancreatitis and chronic pancreatitis on the right. And I just wanted to focus on those. And so compared to people who have pancreatitis without drinking or smoking, the person who's only smoking has an increase, a risk of almost 5 times the average patient for having an episode of pancreatitis, if that makes sense. So compared to somebody who's not smoking, not drinking, it's 1.5 times when you smoke only. What I found so interesting, and I have a molecular mechanism I understand for this, is if you drink mildly or moderately, actually your risk goes down. It's 0.7. So 1 would be, if you are a person who has no risk factors, 1.48 if you're a smoker, but it actually decreases to 0.7 when you drink moderate alcohol. In other words, moderate alcohol, I found interesting that it could actually inhibit the development of pancreatitis. That's why my friends don't get pancreatitis. Moderate drinking plus you smoke, you can see it goes back up. And you can see if you're a heavy alcohol drinker, that's greater than 5 drinks continuously for years, but not smoking, it goes to 1.59. And finally, if you are heavy drinking and also smoking, you can have even a greater increased risk. The point of all this is that moderate and safe drinking is okay for your pancreas, maybe even protective. That's some big people will argue with me on that, but that's what the data here says. Excessive drinking is a problem, and smoking is a problem by itself, and also it adds to heavy alcohol. Now I'll say one other thing. When I see patients like this who drink moderately and don't smoke or smoke a little bit, I say, there could be another reason. So it makes me think really hard about another reason, even including genetic causes. And that's something that I teach my patients, and it's good for you to know when you talk to your doctor about this. The final thing I'm going to talk about, and it gets a little more complicated, but it's just to tell you that we think about this a lot, how the stresses, I have them here, gallstones, high triglycerides, genetic mutations, inhibition of ductal secretion, alcohol and smoking, how they mess up the internal structural machinery of the cell that makes the digestive enzymes. And I have in this slide that excessive calcium influx and other triggers are involved. So that's kind of our research. Why do we think those things mess up this internal machinery? And basically, there are a group of us in the world that work on that machinery and how those get deranged with the idea, and actually some therapeutics that we can come up with that actually prevent the disorders of this machinery. But this is just to show you that the machinery leads to activation of trypsinogen to trypsin, which I said a couple times now is not a good thing because it activates the digestive process inside the cell and actually furthermore causes disruption of this intracellular machinery. And that in the cell leads to what are called inflammatory or pro-inflammatory TFs. Those are transcription factors. And that leads to leaking or those coming out of the cell, and they're called cyto and chemokines and DAMPs. They all have, and there are hundreds of names in those categories, so we don't need to memorize all those. But those then bring in the inflammatory cells, cause inflammation in the pancreas, which shows you the red arrow going down, and also spill into the system, causing maybe lung damage or kidney damage. That's with severe pancreatitis. Now, when you have recurrent pancreatitis, these can happen each time, but sometimes you get less and less if there's more pancreas that gets kind of destroyed to do this when over time. Just have a few other pearls to bring home, and that is once you get inflammation, the inflammation makes things worse. And so the insults I've been talking about, like the hypertriglyceridemia, smoking, alcohol, genetic things, those cause this machinery disorder. And I said those cause this cell that makes the digestive enzymes make here it says cytokines, but there are different molecules that then activate inflammation with neutrophils, and macrophage brings them in and activates them. And then what we found many years ago is they cause further damage. So it's like a vicious feed-forward cycle to cause the acinar cell to cause more injury, more machinery disorders that lead to more of these inflammatory pathways. So the idea with treatment is to stop the cytokines from being produced, stop the attraction of these inflammatory cells to nip this in the bud. And that's what therapies are being developed now in clinical trials are designed to do. And then just going back to recognizing our team, this is an important team. We need to keep them healthy and in good shape to do our digestive function and our endocrine function. And so with that, I'm going to this is my last slide, and I'm going to turn over to Dr. Gavin. There was a publication that just came out in the Journal of Clinical Gastroenterology and Hepatology that with Dr. Yadav, who I mentioned earlier, that really shows that the pain of pancreatitis is associated with physical, mental, and social health. And so what this slide shows is that of those patients with chronic pancreatitis, you can see that have no pain, those with mild to moderate pain, and those with severe pain. And then it shows effects on positive quality of life, QOL, and negative quality of life, QOL. Negative quality of life is like you can't sleep, you're fatigued, you can't function, you can't get out of bed in the morning, you can't do your usual activity, you don't want to go out with friends, etc. So it shows that when you have constant pain or intermittent pain, you're more in the negative quality of life category compared to the positive quality of life category, which you're in when there's no pain. That's the main thing I want to get across, that pain is a driver of multiple things that are going on when you have this disorder. And I'm going to stop there and turn it over to Dr. Gavin. So Dr. Gavin is a close colleague of mine. We work together on a daily basis, seeing patients and designing research to improve the disease. He's an associate professor here at Cedars-Sinai and at UCLA, and his strength is really understand the disease at a patient level and how to deal with disorders of the pancreas and actually do procedures and also apply various integrative health medicine approaches. He actually is considered a leading investigator in the field of pancreatology. He received the American Gastroenterological Association Research Scholars Award last year, and he's working away on that to make improvements in pancreatic disease. So with that, I'm going to hand it over to Dr. Gavin.
Thanks, Steve. So today I want to talk about a couple things. I didn't realize that I thought Steve was Dr. Pandal was going to cover the treatments. I'm going to touch on it very briefly. And then I'm going to talk a little bit about how to discuss pancreatic diseases with your family and what integrative medical approaches can you use. Other non-conventional, I'd say, not the allopathic, but the other things such as yoga, acupuncture, and see if they work for you. Unfortunately, we don't have great evidence in those areas, so I'll try to stress on where there is some research, some evidence to guide you move in that direction. So let's get started. All right, let's get started. So I'm going to talk about just very briefly on treatment options for chronic pancreatitis. It's a very complex and complicated disease. Some of you that know have gone through it, understand that. So I'm going to try and summarize this in a very short, but use a diagram, a graphic to help you understand how we take decisions in this area. So there are several treatment options. One of those is endoscopic therapy. Some of you may have already been recommended ERCP. Basically, ERCP stands for a procedure where the doctor goes with a scope through your mouth to the esophagus, stomach, and then into the duodenum. And in the duodenum, we look at the ampulla. It's an area where the pancreas juices flow into. You saw the diagram by Dr. Pandal where he showed a beautiful picture of pancreas and how the pancreas collects its juices into these tubes and progressively bigger tubes, which we call a duct. And this duct opens up into the small intestine and pours its juices, so normally people can digest food. So whenever there is chronic pancreatitis, and Dr. Pandal went over this fibrosis or scarring that develops over time in patients that get chronic pancreatitis, and this scarring can lead to some obstructions in the way the tubes function, or it can block the tubes and cause it to build pressure. Those are the situations in which we recommend these procedures. If you look at the picture on your right, you can see that in the case of chronic pancreatitis, you can see that the ducts are dilated. The central long tube is the duct. Sometimes can develop stones in it. Sometimes there can be persistent inflammation. Sometimes it can cause one of the side branches of this plumbing system, the ductal system, to build pressure and blow out and form these big pseudocysts with fluid in them. They can also cause problems with the blood vessels in the area. They can cause the blood vessel wall to thin out and sometimes bleed. So some of these, not all of these, but some of these can be addressed with ERCP. Oftentimes, you may have heard about patients with chronic pancreatitis that develop jaundice. And they develop jaundice because this scar tissue that forms in the head can compress on the bile duct and that leads to a narrowing in the bile duct, and it can obstruct the flow of bile that backs up into the liver and causes jaundice. So these are areas in which we call for ERCP. This is not a conclusive list. There are other indications for which we do these procedures. Usually, I think of ERCP when there are narrowings called as strictures or leaks or collections. Those would be the areas. I'll show you a bigger picture just on the next slide so we can talk more about it. Then there are surgical treatments that I'm not a surgeon. I won't go more into it, but there are surgical treatments that can provide lasting benefit. So there's always a discussion about whether we should do an ERCP or go to surgery. I think at our center, we're more we favor endoscopic therapy because it's minimally invasive, and if you get great benefit, then it gives you relief for a while. Sometimes the symptoms come back, sometimes they don't, and if they come back, then we try another round, or then at that point we sit down with the patient and talk about surgery. So surgery mainly involves a surgical approach to removing the diseased pancreas. Some places have an expertise in what's called total pancreatectomy. So they harvest the islet cells that produce insulin and then put that through the vein and give it to the patient through the vein so they can be dispersed in other parts of the body or liver and produce insulin even when the pancreas is gone. This is just a brief overview. So you need to consider everything before you take this treatment. This is not meant to be a conclusive list to help you get the treatment you need, but just to provide you with an overview so it can help you understand the treatments that your doctor offers you. And they're based on your specific situation. Unfortunately, in the pancreas, some universal themes are there, such as pain, pain with eating, chronic pain, but there are a lot of other things that are very specific and very individualized based on the disease and the location of disease within the pancreas. So it's really important to understand that whatever I'm talking about recommending don't apply universally. They apply to certain sections of patients with chronic pancreatitis. So anyway, this is the bigger picture if you wanted to see all the different things that can happen in chronic pancreatitis, and there are ways to overcome these with endoscopy, but sometimes you may end up requiring surgery if the symptoms are severe. But it's really important to understand that at this stage, there are a lot of patients with chronic pancreatitis that have absolutely no symptoms. There are patients with minimal imaging studies but have a lot of symptoms. So there's this whole spectrum, and it's really important to know where you stand before we can offer any treatment. For example, there are some diseases, for example, that are very simple. You have an ear infection and you have pus coming out of your ear, you give antibiotics. That's sort of very simple. You can hear it from your friend and apply it to a wide range of patients. But pancreas is not the same way. There are people with pancreatitis that have had a certain surgery, do well, others may not. So you have to cater to your doctor will evaluate you and give you a recommendation based on your very specific information. Also in the chat, I've noticed that some patients do want to know very specific situations. So it's hard for us to evaluate over this meeting and give you very specific recommendations unless we view pictures, images, and we need a whole lot of things. So I think it's probably prudent to stay away from any specific questions, but we can provide you with a general understanding if needed. So I want to quickly touch on the other areas. How much time do I have, Trish? Do you know?
Yes, you're all set. We still have time. We don't finish until 8:15.
Okay. Well, So I'll talk to you a little bit about chronic pancreatitis and how you can talk and approach to other members of the family, of the society, or your workplace. It's really important to help to be very honest, open, and talk to them about the problem. I'm not saying that you should talk to everybody, but talk to the ones that really need to know. And when you convey to them, it's important to say that you have a chronic condition of the pancreas. And it can cause pain. There can be problems with diet and other things. You can explain to them that this is a long-term inflammation and that you're working on medication, lifestyle changes, and that you may need procedures in future. So it's really sharing this condition with others that helps them understand how they can help you in these situations when you have trouble. When you talk to somebody, just make sure you choose the right time and place. You need to have a good understanding of your situation and how it affects you so you can effectively convey to them. And make sure that you can have an open conversation with the person you're talking to. And if it's something that that you're in a position you have to convey to someone that's outside of your family, it may help to have a family member with you when you have this critical conversation. With your family members, make sure you ask for support. Just be very clear. And sometimes I think we need help, and we are telling about the problems we have, the problems that you're undergoing to your family members, but you're not really clearly conveying what it is that you expect from them. So make sure that when you are seeking support, that you tell them exactly what it is that you're looking for, so that they can understand and respond appropriately. Of course, I think all the participants here are doing really well in the sense that you learned the need to form support groups, to join an online session today, and to learn more about your disease. And it's really important to remember you're not alone. There are a lot of patients that we see that have trouble. Yes, many of them were able to help. Sometimes the others were able to manage. And some patients can have very difficult situations where surgery may be the only answer. So it is a case-by-case basis, but remember that you're not alone and that you participate in understanding your disease with yourself, with by your own reading, learning, with your peers, and also with your healthcare providers. There are several resources, and you've reached the main and most important resource today, National Pancreas Foundation, providing a lot of help for people in your situation. Also, American Chronic Pain Association, if pain is your main symptom, or joining other Facebook groups that can help you get more information. So I want to touch briefly on some of these complementary and alternate medicine approaches. This is a very difficult area because there are a lot of complementary medical approaches, supplements, other treatments that benefit patients. The problem today we have is number one, we don't know which of these alternative medical treatments help what group of patients. That means that let's say there are 100 patients that approach us with chronic pancreatitis. I may ask them to try some complementary medical treatments, like let's say that we tell people to go participate in yoga and to help relieve stress and when symptoms come on, to learn to meditate. We don't know out of those 100 if there may be only about 20% of them that have true benefit, but we don't know which 20% have those. In the case of yoga, it's very easy to advocate for it because all 100 of you can do yoga and have not just chronic pancreatitis benefits, but other benefits as well, and it has no harms. But let's say we recommend some medication or supplements. It's possible that supplements can cause side effects in some patients and benefit others. So we don't have a way to recognize that. There are studies, and it's really important to understand studies in medicine and how knowledge progresses in medicine, because oftentimes I will see a patient bring one study and show it to me and say, well, here's the proof that this thing works. And it is true that it may work in selected group of patients, but there may be 25 other studies that show that they don't work. And so the medical knowledge doesn't progress by leaps and bounds, and it doesn't just take one study and believe it 100%. Medical knowledge progress slowly because there is so much noise in our data, meaning there's a lot of noise in the way research is done. It is not very clear to us just based off of one study that something is of benefit or value. So with keeping this in mind, let's just move forward. I'm going to only talk about where there is some evidence and what that evidence is, so you can take your decision. I don't have a very strong recommendation on which complementary alternate medicine you should try, but if you try something and it works for you, you can stick with it, and if it doesn't, then don't do that. So that's what I'd say. That's the overall recommendation, but I'll just briefly give you an overview. So, of course, we need to rethink about chronic pain, which opioids have limited value in, and they may cause a lot of harm, in fact. So the move is to go away from opioid pain medications, although I do realize that there are some of you that really need this pain medicine to function. And I'm not advocating that we take it away from them, but I'm advocating that we be judicious because opioids have their own problems. There are several problems with chronic pain, is that it involves so many levels of, it's different from short-term pain. It's got psychopathology, it's got a lot of social meaning, and benefits from these type of medications may be hard to judge in chronic pain. There's a need for complementary medicine, and therefore we're talking about it today. And that there may be need for more than one type of treatment, and that we need to understand that these treatments need to be provided in a very complementary manner, so that they can have a synergistic effect. Meaning, you take one pain medicine, then you try yoga, then you take meditation, then you try distraction techniques, acupuncture. These are all different things that you can try and see what works for you. And I just went over this, is that opioids are not good overall for non-cancer pain. There's good data from this long-term use patients showing that it's probably not good, and therefore we need to use complementary and alternative medicine. So let me highlight this one paper briefly. This was published in a journal called JAMA, Journal of American Medical Association. And this study talks about various types, such as acupuncture, herbal remedies, and other complementary medical practices that have given us some knowledge. There's not a great amount of research, but some knowledge. In the U.S., about 40% of U.S. residents rely on these complementary and alternative medicine. So I'm just going to call that CAM. About $34 billion are spent out of pocket in CAM treatments. And more than 50% use it mostly for chronic pain, and the other half uses it just for physical health and psychological well-being. This just describes what the state is of these CAM therapies today. There is a lot of mounting evidence that mind-body approaches may be beneficial and useful in this specific group. And that there are several studies, so I'm going to go very briefly. I don't want to take away Jane Holt's time, so I'm going to try to summarize these slides for you without going into the details. There's electroacupuncture. This was performed in rats. It's an animal study phase, so something to think about looking at, see if there's any evidence in the next 5-10 years about this in humans. It shows some promise in animals. Yoga is just an amazing study. This was published in 2007. It's a randomized controlled study of about 60 patients. Yoga was found to be very effective in improving quality of life in patients with chronic pancreatitis. All they did in the study is they took two groups. They provide standard care to both groups. One group, in addition to standard of care, received 12 weeks of yoga, bi-weekly yoga session, and they had an overall improvement, quality of life, stress, mood changes, alcohol dependence, and appetite. And so I think, randomized controlled trials are the gold standard for research in medicine, and yoga certainly seems to help with that. Then about dietary counseling and supplements. This is a really good study on medium chain triglycerides, and what they found was that dietary counseling and supplementation had similar benefits to medium chain triglycerides, meaning these medium chain triglycerides didn't have a great benefit in this overall population. So if you're on it, if you're using it and it's of value and benefit to you, please by all means continue to use that. But this study suggests that dietary counseling for a balanced homemade diet is as effective as any other commercial food supplements that you may buy. So it's important to see a nutritionist and get that counseling in addition to what you're doing. I'll be very quick on antioxidants. There are studies to show, so that's a really well done study, shows that there is a significant reduction in pain in these patients with recurrent acute pancreatitis, chronic pancreatitis. But there are other high quality studies showing that they do not benefit. And so I looked for some really large studies called Cochrane reviews. They put together all the data that's available and try to draw a conclusion based off of that. So in this conclusion study, it's a synthesis of multiple studies. It says that antioxidants may reduce pain, but it's really important to know that adverse events can happen in 1 out of 6 patients. So it's really important to keep in mind that not all supplements are risk-free. So if it's not of benefit to you, I would say stop taking that medication. Yeah? And so obviously more research needs to be done in this area. Cannabis is another favorite. I'm just giving you a little overview of GI diseases. It's been tried and there are randomized controlled studies being done in another kind of gastrointestinal disease called Crohn's disease. There are several case reports that cannabis may actually cause acute pancreatitis. So there is mixed data. I know that there are some of my patients that have told me that they found really good benefit, but I'd say be very cautious before you decide to start on this, because the data is not all there, and there is some suggestion that it may in fact harm people. Of course, there are some people that have derived benefit from CBD oil and such. So I would say think of it as an individualized treatment. It's probably not a treatment that I would recommend to everybody. If you have benefits, stay on it, but otherwise be cautious, because there's very little that we know about cannabis, and that we need to be really cautious, because even when tobacco first came out, it was thought to be a great substance with no negative effects, nothing bad. But we may learn more about cannabis in the next 20, 30, 40 years. But for now, I would be really cautious. So there's this really interesting study, about internet-delivered psychotherapies. And I think the summary of this slide is that they may actually be beneficial in chronic pain, despite them not being beneficial for anxiety that this review found that they may actually help patients with chronic pain syndromes. Then finally, this is a study that Dr. Steve Pandal, he's the national leader in pancreatitis, my mentor. He's really amazing. Has a lot of different areas of pancreatic diseases that he's involved with, and one of these large studies is a national registry trying to understand a lot of things about pancreatic diseases that we don't know yet. I think I look forward to a lot of discoveries this study is going to make. It's called the CPDPC. If you want to learn more about it or participate, look up CPDPC, Chronic Pancreatitis, Diabetes and Pancreatic Cancer Consortium. You may have one near you. There are about, if I'm right, there are 9 centers in the U.S. That enroll patients. Please take part in this. This particular slide is about a web-based study on cognitive behavioral therapy in pediatric patients with pain, pancreatitis pain. And so the study is still ongoing. We look forward to the results from the study. So with that, I will move on and give way to Jane Holt's study. Trish, do you want to introduce Jane Holt? I don't think she needs an introduction.
Thank you. Yes, we have Jane Holt, who's a co-founder of the National Pancreas Foundation, and she's here with us this evening to talk a little bit about one of our upcoming programs that we're working on, and it's the National Patient Registry. So I'll turn it over to Jane.
Thank you so much. So I do want to thank all of you for joining the webinar today. As you heard, my name is Jane Holt, and I'm co-founder of the National Pancreas Foundation, but I'm also a patient with chronic pancreatitis, and I've had chronic pancreatitis for about 35 years. And today I'm here to tell you about our new patient registry and basically how the registry will help you as a patient, and also how sharing information from the registry will help you when working with the medical community. So there are several ways that I'm going to be explaining that to you. But we launched the registry in May of 2022, but we didn't really start promoting it until September. But as of last week, we have 600 patients who have signed up. So we think we're doing very well, so I'm excited about it. So our registry is the first patient registry impacting all types of pancreatic disease, including pancreatitis, pediatric pancreatitis, and pancreatic cancer. And it serves as a conduit to help patients and caregivers access health information they need to navigate the challenges of pancreatic disease and take steps to achieve health and wellness over time. So access to health information, as we all know, is critical for patients to stay informed and to help communicate with their healthcare providers so that their medical needs can be adequately addressed. So with our registry, you can connect to most patient portals. So you can connect to your medical records at almost every medical institute across the country. And the other thing that's fun about our registry is you can also connect to your fitness and health tracking devices, such as Fitbit or Dexcom, which tracks your glucose levels. And the other thing that I really like about it is you can connect to DNA sequencing programs, and all of this information will be gathered in one place in the registry. Next slide, please. The registry is extremely patient-friendly. You just need to set up your profile, connect your records, and explore your data. Once you have done that, you now will be able to view all of your health history in just one private and secure place. So this is going to be great for our patients. Next slide, please. What happens, the first page you come to is a profile page. And on the profile page, let's try the next slide. Let's see what happens on the next slide. There it is. You can set up your profile, and it's a very simple thing. You just add your name and your date of birth, your zip code, and your sex. And then if you look down lower in the corner, you can see where if you have more questions, you can click on it to learn more about privacy and things like that. And the other thing that I really like about this entire registry, if you look down at the very bottom right, you can see a little icon there. And if you click on that icon, you can start a chat with people at Seekster. So if any time during your process of signing up for the registry you have any questions, you can chat with somebody live right at that point. All righty, so maybe we'll go to the next slide. So we really feel that the most important part of our registry is downloading your medical records. And you can do it from multiple medical centers. So for me, as an example, I live in Boston and I see specialists at Mass General Hospital, at Brigham and Women's Hospital, at BI Deaconess. So I have records at all those three places. But now with the registry, I can just go to the registry and see all of my different records. So for instance, if I go to see a new doctor, or basically if I go to see a new doctor and he asks me, when's the last time you had an MRCP? I'm not going to really remember, or I'd have to give a rough idea. But instead, I can go to my phone, I can look it up in a minute, I can tell him exactly my last MRCP, where I got it, and what the results were. So it's a very great tool for sharing with your doctors. That's going to be tremendous. So this is just an example to show you. So when you go to the registry, there's things are totally separated. Where you can find out you can separate by medications, allergies, vaccination, treatments and therapies, procedures and surgeries and things like that. But this is just an example. So this is just one of the many different visualizations that you can have. This is a chart of how this person's glucose was doing over time, and whether it's going up or down or where it was. So it's not only you can see the records, but it gets visualized at times, which is really fun for the patient. And so another very important part of the registry is the surveys. And when you sign up for the registry, you're asked to answer questions about the onboarding survey. So when NPF was developing the registry, we worked very closely with a steering committee, the registry steering committee, which was made up of a group of well-known physicians, researchers, and patient advocates. And this group advised us throughout the whole process of developing this registry. The onboarding survey, which is what you're seeing just a little bit of here, was their suggestion. And this is one of the first this is the only survey you'll get right now as you sign up. But it asks very basic questions about your disease, but these answers are going to be very helpful in the future. So all of the information NPF can see is de-identified. So we have no way of knowing who answers the survey, but we can see things like many of the registrants have how many of the patients have chronic pancreatitis, and how many have pancreatic cancer, or how many are male, how many are female, or what are the ages of the patients, what states do they live in, what is their race. Things like this are really important for us to know, just to get an understanding of who our community is, but also it'll help us in marketing to know what groups we're missing and where we have to go to find them and get them to sign on. But it just is going to help us, and it'll also help research and just a general understanding of the disease. Next slide, please. So we have a lot of things also that are coming soon. One of the things that has always been a problem for our patients is when there's an emergency, or you're traveling, or even when you're just in between going to a new person that is caring for you, is to be able to have access to your personal health information to make sure that you're being cared for properly. So the thing about the medical records is you can easily share important details about your personal history. And also we have added something to this. It's called the emergency room health card. And this we've worked on for a while with different medical groups and patient advocates. And we have one for pancreatitis, and we have one for pediatric pancreatitis, and we have one for adult pancreatitis. So when you go to your emergency room, we'll have these emergency cards give an idea of the important ways of treating the patient with these diseases. And with this, here's an example of the pediatric card. And with this, and with the records from your medical records, when you go and sharing both of these with the emergency room, will make it so much easier for them to realize, yes, you are indeed a patient with pancreatitis. And for those places that aren't very familiar with pancreatic disease, they will give them ideas of the best way of treating you. And the pediatric ones have been being used for a while with the pediatric patients, and it's been very successful and very helpful. So we're really excited about this. Next slide, please. The next thing that we're adding is the Promise 29, which is a quality of life survey. And it's a set of validated health measures designed to capture patient-reported information on various aspects of quality of life, including physical, mental, and social health. I'm sure many of you have filled out a quality of life form in the past, but the nice thing about ours is it's right on the registry. So right now, our steering committee has recommended that you fill it out once and then every 6 months after that. And one thing that's nice is you will be able to track your quality of life over time. So I don't know about you, but I always think, well, I can't remember. How was I feeling, 6 months ago? Did I feel as badly as I feel today, or am I feeling better? And if I'm feeling a little bit better, well, why? What have I done? What have I done to make a difference? So we feel like it's going to really help the patient in understanding, what's going on with them over time. But also, it'd be really nice if you go to your physician's office and you've recently done a quality of life. You can say, hey, I scored, 7 on the quality of life. What should I be doing? How can I make it better? And then it just opens up a way of starting a conversation with your doctors. So that's another thing we're very happy about. The other thing that's going to be coming sometime this summer is a VioScreen. And VioScreen is a 90-day food survey, and it's been made specifically for patients with pancreatic disease. And the survey is great. I've done it. Doesn't take very long to do, but it has wonderful pictures and explains very easily the size portions and things like that. So it's a fun survey to do. But the nice thing about it is when it's done, you get a report, and it not only gives you a score, but it indicates what you are doing is healthy, what you're eating is healthy, and how you can improve it, and how you could make your pancreatitis better by eating more of X and less of Y. And so I think this is going to be another wonderful tool for our patients. And again, another thing that you can go to your doctor's office and say, hey, I didn't score very well on my nutritional survey. What can I do to improve it? And hopefully they'll recommend the National Pancreas Foundation cookbook and you'll be all set. But anyhow, so these are the 3 things that are coming. That'll be more things to help the patients, and also I think will help with conversations with your medical health professionals that we're excited about. And could I do the next slide, please? But by participating in the National Pancreas Foundation registry, you'll be sharing de-identified health data, and you can contribute to collaborative efforts to aid in the fight against pancreatic disease. This patient registry is the only patient registry in the country that's done by patients, and it's just going to be a tremendous help to all of our researchers. I mean, just think about the information you'll have in your registry. If you do everything that's available to you, it'll include your medical records, your exercise patterns, and depending on the device, your sleep patterns, your DNA, and soon your quality of life over time and your nutritional records. If you're diabetic, you'll have your glucose patterns from your detox system. So, I mean, just think about how much research could learn from all of this information, which will be all collected in one place. So think it's going to be a tremendous help. And by you entering everything into your registry, it will help make this work even better. It'll also help in identifying patients that would be appropriate for certain clinical trials. And we'd be able to reach out and let you all know about the clinical trials that are available for you. And as Dr. Gadam said, the more patients get into clinical trials, the better the care will be for us. So if we can find clinical trials that will work for us, and the National Pancreas Foundation can help at all with that, we're just going to improve our life or the lives of others with pancreatic disease. So it's all really important. And soon we will also have educational library with information on the NPF and on our disease and all of the things that are happening. So we're very excited about the registry. Can we hit the next slide? There we go. So our biggest thing for you is to ask you to join our registry. It's really easy to use. It'll help you, it'll help our researchers, it'll help NPF, and together we can make a huge difference. So that's it from me.
Thank you, Jane. So we have time for a few questions. I don't know if Dr. Gavin, if you want to take a look at those, or Dr. Pandal, and answer a few of those live.
Steve, can I read a question for you?
Okay, sure. Thanks, Shri.
Okay, okay, how likely are CFTR mutations to cause pancreatic cancer?
The known information is that they're not very likely to cause pancreatic cancer. Now, it depends on whether you have classic cystic fibrosis or you have one of the variants that causes pancreatitis, but not cystic fibrosis. There is some increase in pancreatic cancer with patients with cystic fibrosis. It's a small increase, but it's real. And the patients with pancreatitis without cystic fibrosis, it's not clear yet.
Perfect. Thank you for answering that. Let me look at other questions. I guess I could take this one. This is related to an ERCP. I am 55-year-old Black female who had original onset of acute pancreatitis from an ERCP. So it looks like acute pancreatitis as a result of complication from a procedure. And she goes on to write, I now have chronic pancreatitis. I also had a sphincter of OD diagnosis and had surgery, after which I still suffered attacks. I would love to know if there is a research group I can be part of. So, good question. I think the issue is there's an entity called sphincter of OD dysfunction. It's called by different names in different parts of the country and the world. And we don't really understand what causes this kind of pain. Originally, it was thought that the sphincter itself causes pain. So I don't know of any specific groups that you can join. You could look at unexplained abdominal pain groups, chronic abdominal pain, duodenal hypersensitivity, visceral hypersensitivity, and other things like small duct pancreatitis. Those may be areas you want to look at. One of the other things I worry about in this particular person is that you could have strictures in the pancreatic duct as a result of your prior complications. So I think you may want to revisit with your healthcare provider to look at an MRI or something to study the pancreas itself.
I can take a couple. There's one that says, well, pancreatin, which is a form of pancreatic enzyme replacement like Creon or some of the others, if that has lipase in it, which it does, how's that lipase different than the lipase that ends up elevated in my blood when I have pancreatitis? That's a really good question. So the lipase that you take in the digestive enzyme aid or treatment actually stays inside your intestine. It doesn't get absorbed into your body. The lipase that comes from your pancreas is leaking out of the pancreas into your blood. You can imagine that your pancreas is supposed to take that lipase from those places where we said it's made, those cells, and it's supposed to put it inside of ducts, stay inside those ducts, and go into your intestine, stay inside your intestine, not escape into your body like it does with pancreatitis. And pancreatitis, the barriers to this pipeline that's supposed to take the enzymes into your intestine and outside your body, that's why we call it exo, it goes outside your body. The barriers between the ductal cells and the acinar cells and your blood get broken down. So everything, the mechanism to keep the lipase inside your body gets broken down. That's why it goes into your blood and causes damage. So I hope the important point here is that the system is set up so that when you take things orally, or if your pancreas secretes correctly and makes things stay inside the pipeline, the lipases and trypsin and all those things aren't escaping outside the pancreas, going in the body and hurting you, because once they're in a normal system, they're safe. So that's one. Another, there are a couple having to do with cancer risk. And also does pancreatitis shorten my lifespan? So there is a pancreatic risk, as I indicated. Somebody put down 25 to 35 times. It's not quite that high. It's probably somewhere around 7 to 10 times, but that is increased risk above the normal population, the average population. So to think about it, say, in the average population is pretty rare. And if you increase it like 7 times, that still means your chances of cancer are low. It just means that it's increased risk, but it's still low. You individually may have only, I would say, a couple percent increase above the average population. But it is there. We have to be aware of it. And when I see patients, the patient and I are always discussing that risk and how we can, if there is something that's different that we should investigate further, another MRI or another endoscopic study that Dr. Gavin would do. We're always talking about that when something's changing and we're worried, but still the overall risk is low. I hope the way I explained it makes sense, because sometimes the numbers are scary. Okay.
Sure, I can attempt these questions. I think there's a series of questions by Bhuvan. And Bhuvan, it looks like your one of the answers I already replied is that it looks like you have what is called this pancreatic divism. The question here is that he or she asks, the main pancreatic duct is not joining the common bile duct and appears to drain into the duodenum proximal to the major papilla. Main pancreatic duct is not dilated. And it's a really good description. It basically says you have what is called as pancreatic divism, which is you're born with this condition. About 15% of the general population is born with this condition. It is attributed that people with this particular condition may have recurrent bouts of pancreatitis. It's an area of controversy, and that's why I sent you that link to a website. It's called pancreasdivism.com. It's actually a National Institute of Health sponsored randomized sham-controlled study called SHARP, a SHARP trial. So it really goes over in detail all the controversies in that area. Even though it's thought to cause it, when there are recurrent episodes and I start to see a dilation, we do right now as a standard of care, we do perform an ERCP to open that sphincter, but it's still an area that continues to be controversial. They have enrolled about more than 50% of all the patients needed for the study. So it will come out in the next 5 to 10 years. In the next 5 to 10 years, we'll have a definitive answer from this study. Yes, can pancreatitis shorten your lifespan? 2 episodes? Probably not. It depends on how severe the episodes are and whether you have a necrosis of the pancreas. Those are all things that help us determine. He or she also goes on to write that she's had 2 episodes so far. It moved back to the chest, had a second episode. Amylase, lipase were elevated, and the lipase was as high as 15,000. You're right in that you likely had an acute pancreatitis episode based on all the information you're giving us. But the 15,000, the number itself is not that important. It's important how you do. It's more for diagnosis. Often, I think we think of higher number being worse, but that's not supported well by the data. So I don't think you should make too much of that number itself at this point.
A couple here. So one is by somebody with an Indian surname, asked if people for the registry only are from the U.S. or they can be from, or can they be from other places? And this is for Jane. And I'll just say, parenthetically, Dr. Gavin and I go to India and we do studies in India, and India has a very high rate of pancreatitis, and it's probably a little bit different cause in India than the United States. And And so there probably would be a different, let's say, data that we get from different countries. Jane, you want to take that?
So the answer is right now, it is just in the US. It gets a little bit complicated when we go to other countries. First of all, language, but also, measurements of everything is different. Lab tests are different. So we would like to be able to move on to other areas geographically, but right now it's easier for us to just keep it to the US to get it up and running and decide when we can move someplace else.
Okay. There's one more I'll take and then hand it back off to you, Shri. So this person states their age, says I'm 70, sorry. Sorry for what I said. So 70, and she asks, will her creon need increase? She has a second question, can I cook with alcohol? Good question. So on the first one, no, your creon needs will not increase. I don't think there's anything that states that the need for digestive enzymes changes with age. Around cooking with alcohol, so I indicated, people don't have pancreatitis. I think the risk of alcohol is causing pancreatitis pretty low. So I think it's fine to cook with alcohol. I do caution my patients who have pancreatitis about, well, diet, obviously, we've talked about, but also with drinking and smoking and being in rooms with drinkers and smokers. And I'll tell you that in children, there is a study, and I'm not sure this has been published, but it comes out of one of our working groups in the consortium that we talked about, and that is that children who have pancreatitis due to a genetic cause actually have increasing attacks when they're in rooms with people who smoke. So it says to me that once you have pancreatitis, you are more sensitized to your environment. So keep that in mind. And I'm not advocating smoking for anybody. So don't take that away, but take away that, if you have pancreatitis, you might want to stay away from smoking areas, family members who smoke. And I would say, my colleagues say no alcohol if you have pancreatitis, in contrast to if you don't have pancreatitis. I'm a little bit more liberal. I say that if you're doing well, maybe a social glass of wine or something like that's fine. That's just my own opinion. We don't have any data other than what I've said, basically. You want to take some, Shri or Jane?
Okay, I think it's almost the end of our time, but I'll take one last question from Beth. I see that she's had her grandma died of pancreatic cancer, and she has chronic pancreatitis and also Crohn's disease. I think she's concerned about the risk of pancreatic cancer. So I can tell you that if you have one family member, your grandmother means she's a second-degree family relative, there is an increase in risk of pancreatic cancer, but that risk is very small. Like Dr. Pandal was saying, that even if your risk went up to 7-fold, you're still a small risk in absolute numbers. So your risk does go up if you have a second degree, but it's not high enough where we would start to screen you. But you also have chronic pancreatitis, so that also puts you at risk for pancreatic cancer. So I would suggest that you can have, I don't think she may have had a genetic testing done at the time, your grandmother. You could see a genetic counselor to see if there's any genes that you have that put her and that were transferred to you and thereby increase your risk of pancreatic cancer. If that is something that if it shows that you are at a genetic risk, then certainly you may need more intensive screening. And most chronic pancreatitis patients will need some form of screening. I don't think we've seen it yet in national guidelines strongly. But Steve, is it your practice that you screen patients with chronic pancreatitis for pancreatic cancer, especially if they have had it for a while? What's your?
I don't. I follow them carefully and say that, if anything changes, let me know immediately, and that we'd evaluate. But I've not, in my practice, I see actually at this point I'm only seeing patients with pancreatitis actually. And I don't think I've had a case that's turned into cancer. I will tell you that we have a national cohort study through the thing that we talked about, CPDPC, Chronic Pancreatitis, Diabetes, and Pancreatic Cancer Consortium. By the way, that was Jane was the person that started that many years ago. That was her initiative from NPF. But to tell you, we have 1,500 patients now we're following in that group. And we do have patients that have shown up with cancer. In that 1,500 patients, we have 4 patients that have developed pancreatic cancer. That gives you a rough idea of the number when we're looking carefully. I mean, there are more questions. There is one other that was interesting to me. Somebody, and I'll just tell it here. So the person says, my stool has yellow, oily looking stuff in it. Okay. So for me, that I shouldn't say this, but this is from a pancreatologist and gastroenterologist. That's like music to my ears. No, I shouldn't say it that way. That is like a sign that indicates you're not digesting the oil in your food, and it means that you're low on pancreatic enzymes. That's like one of the most specific things that we see. And I remember one of my first patients when I was very young brought me, it was before digital cameras, it was a Polaroid camera, and he brought me a Polaroid picture of his toilet bowl. And I can still remember the picture. It was the oil droplets that were a little bit yellow and still. So if you have that, tell your doctor.
Yeah, I was just going to add that I think all patients feel a little bit funny about talking about their stool when they go to the doctor. And I think one thing that the point you just made is so important, because if there is a change in your stool and you see things like that, it really helps your doctor to understand what's going on with you. And it's an important item to tell them. So good lesson learned. Thank you.
I should have said music to my ears. It's like specific to my eyes. How's that?
Yeah, no, it's perfect.
Yes, I want to thank you all. Thank you, Dr. Pandal, for taking the lead with this. And Dr. Gavin, we really appreciate all the support that you give to our patients throughout the year and for tonight's webinar. Obviously, it was very popular, and I just wanted to let the audience know that we will be sending out a follow-up email tomorrow, which will have links to our website, links to how they can sign up for the patient registry. And if you have any further questions, please feel free to reach out at info@pancreasfoundation.org, and we will be happy to answer and help you any way we can. But thank you all for joining tonight.
Good night.
Good night. Thank you.